or Penta 1, as we all call it now. While an under-immunized child is a child that has missed Penta 3 or the DPT 3. And then we also talk about mixed communities. And when we talk about mixed communities, we're actually talking about clusters of zero-dose children and under-immunized children living in vulnerable communities. Next slide. Okay, so looking at what is the current zero-dose status, like I said earlier on, most of the zero-dose children reside in just 10 countries. So these countries account for about 59% of zero-dose countries. Interestingly, 3 of those zero-dose countries also have the lowest DPT-1 coverage. So it's good to note that having a high number of zero-dose children does not translate to very low DPT-1 coverage. For instance, only countries like Yemen, Afghanistan, and Angola are actually cross-cutting by having very high number of zero-dose children and also having very low DTP-1 coverage. 5 of the countries that account for 59% of zero-dose children are from Africa and accounting for almost 5 million zero-dose children. And then 5 of these countries that have the lowest DPT-1 coverage are also from Africa. So we see that there is a problem that we need to deal with on the African continent. Next slide, please. And looking at this slide, we can also see that a lot of these zero-dose children live in fragile setting, in conflict areas. So we can see we have Yemen. Margaret, if you can adjust it very well so they can see it. We can see Yemen. We can see Afghanistan. These are countries that have fragility or have a lot of conflict areas. We can see Somalia. Margaret, it's over. Is it from my side or from your side? It's okay. So it's fine. No, don't zoom it, please. Don't zoom it. It's okay like this. Thank you. So we can see that the orange colors are countries that have that are fragile. So when we talk about fragility, we're talking about countries that are either vulnerable or have a lot of conflicts over time. And we can see even Nigeria, accounting for over 2 million zero-dose children, is also a country where we've had a lot of fragility, a lot of vulnerability, and a lot of conflicts. 55% of all unvaccinated children live in these fragile settings. So looking at the current situation in Africa, Africa is home to the highest number of unvaccinated and also under-vaccinated children. Half of the top 20 countries in the world with the largest number of zero-dose children are in Africa. And then we account for over 12 million under-vaccinated children in 2021 and 8.7 million zero-dose children. These numbers are high. Interestingly, Nigeria and Ethiopia have the largest number of zero-dose children. 2.1 million in Nigeria and 1.1 million in Ethiopia. And this data is from the WUNIC, recently released WUNIC 2023. 2 in 5 zero-dose children live in one of the countries, either Nigeria or Ethiopia. Next slide. Africa, interestingly, we still, even though we are home to the largest number of zero-dose children, the Afro region also leads in the progress of DPT-1 coverage. So we've seen improvement over time from 2019 to 2023. And we're looking at 2019, we all know that that was when COVID struck. We had interruptions in services, but after 2020, 2022, many countries picked up, and we've seen huge improvement on the Afro region, more than we've seen either in the Americas, in the Eastern Mediterranean, the European, the Southeast Asian, or the Western Pacific region. And this is still based on the WINIC data that was recently released in 2023. We can move, Margaret. Okay, so what are some of the barriers to the immunization uptake? I've tried to group them into 3 broad categories. The first category is the caregiver-related drivers, and we look at logistical challenges. Most caregivers cannot afford transportation to go to health facility. Most of them, even if they can go once, they cannot go 4 times, 5 times that we have required that they should go for routine immunization. So that is a barrier to immunization uptake because they cannot move and the immunization services are not taken to them. And then maternal workload. If most of the time in our settings, it is the mothers that take the children to the facility for vaccination. Where the mother is working, where she has a lot of work to do without support, and she's unable to take the child for immunization, that child becomes a missed child if the child had started, or becomes a 0 dose if the child never started any routine antigen. And then misinformation and disinformation. So it's either they don't have the adequate right information on vaccination, on the schedule, on the importance, the need to take their children for vaccination, or the information they have actually misleads them. We have so many disinformation around vaccination causing, making children sick or causing infertility. So if a caregiver has this kind of information, definitely the caregiver wouldn't go to the facility for vaccination. And then maternal education and socioeconomic status. Importantly, education is a driver for healthcare service seeking behavior. So if a mother is not educated, you find out that she does not have faith or she does not believe in the healthcare services, she will not even go to the facility, even for delivery. So that affects immunization uptake. And then cultural and religious concerns, where the culture does not allow the woman to come out and she's the major caregiver to the children, she cannot take them out to the health facility, or where we have religious concerns, religious beliefs, where our religious leaders have told the followers do not take the vaccine. It's also a caregiver-related driver that hinders uptake of immunization. And then lastly, under the caregiver-related drivers is the issue of lack of trust. Lack of trust in the health system, lack of trust in the government, lack of trust in anything that is provided free, because in our region, immunization is provided free. And then we'll look at the health system drivers. Poor infrastructure. We don't have adequate vaccines. If I'm going to match both adequate vaccines and the infrastructure, we don't have the supply chain to store the vaccines. You go to a health facility, they are dilapidated. There's even nowhere, even if a cold chain equipment is bought, there's nowhere to keep it because the infrastructure is really, really bad. So when the healthcare worker goes, when the caregiver goes to the facility and there's nowhere to even sit or where they can wait for vaccination, then they become discouraged to go back again. And then inadequate workforce that also adds to lengthy wait time because we don't have the human resource for health. Where they're not adequate, to provide the services within the health facility. If you go to a facility, you find out that the same healthcare worker that is providing immunization services is also the facility in charge, is also the, in quotes, the doctor that is providing healthcare services, is the same person that is taking antenatal services. So it becomes cumbersome on the healthcare worker, and caregivers have to wait long time to be able to be attended to for vaccination. And because vaccination is a preventive healthcare service, people don't see the need why they should go to a facility and wait to be attended to. And then, of course, inadequate resources. And then looking at the community and social drivers, we have ethnic disparities, urban slum residency. In terms of ethnic disparity, if a healthcare provider is from a different region from where the health facility is located, people don't have trust to go there. They feel this person is not part of us, so why should I go to him? I don't have trust in whatever he or she is going to be providing. And then issues around poverty. People feel that I haven't eaten, I haven't been able to provide for my family. Why should I spend money in going to a facility for vaccination? And of course, the regional disparities, conflict and fragility, and then sociocultural beliefs and practices. And a lot of these drivers are actually cross-cutting. So especially between the caregiver-related drivers and the community and social drivers. Next slide. So what are the key drivers? We've seen the drivers for the barriers to immunization uptake, but what are the drivers that will push immunization uptake in our communities? First of all, I've also grouped them into the same category. So caregiver-related drivers, cultural and religious sensitivity and sensitization. So we need to find a way to sensitize our caregivers, educate them, build trust in our healthcare system, so that by the time the mother is making a decision to go, she's making an informed decision based on trust that she has in the healthcare provider, trust that she has in the system. Educate them, and then let them have access to immunization information. What is their perception about the benefits of vaccines? So we need to do a lot of education. And then importantly, we've also noticed that maternal education is a key driver to immunization uptake. If a mother is educated, at least to secondary school level, she's able to understand the need for healthcare services. She's also able to understand the need to get her children vaccinated and the importance of vaccination. And then health facility delivery. So if a woman delivers in a facility, as against if she delivers at home, she's more likely to continue vaccination. Because the child is more likely to get the first, the birth dose, and she's educated, she's enlightened, she's sensitized on the need to come back for other vaccination. So there's a higher likelihood that she's going to continue the vaccination process for her child, and that she's going to also educate her other peers. And then access to maternal health care is also a key driver for immunization uptake. In terms of health system drivers, and I've taken note of the time, having skilled healthcare workforce is very important. Adequate vaccine supply. It will definitely not be good to have a caregiver come to the facility for Penta 1, and then we find the child does not get it. That caregiver will be lost to follow up. The caregiver is not going to come back. And then improvement in our infrastructure, improved health financing, flexible vaccination scheduling. When we talk about flexible vaccination scheduling, is using like a human-centered design to engage the community in the timing for vaccination. For instance, if you have a farming community where everybody goes to the farm early in the morning, scheduling vaccination times in the morning wouldn't work for that community. So we're going to have high numbers of zero dose in such a community. So flexible vaccination scheduling is very important, and then supportive government policy. Lastly, looking at the community and social drivers, we need to do a lot of community engagement, social mobilization, having vaccine and immunization advocates within our communities to be able to continually engage the community, engage the heads of household, engage our community and religious leaders to sensitize them on the importance of vaccination, and then improved access to health facility. And sometimes we might have to involve our security personnel because we need to secure our healthcare workers that go out to provide immunization services, especially in conflict areas. Next slide. What are the opportunities for zero dose reduction? I think I discussed most of them in the previous slide, but just to talk about a few of those opportunities again, integrating immunization with other healthcare services. For instance, if a woman comes for vaccination, can she also get checked beyond just the child? Can she get checked for her hypertension, for diabetes? And can we have things like insecticide-treated nets given to women that complete vaccination as incentives? And then having community-based strategies that work for the community, involving them in the scheduling, using human-centered design, even citing of where outreaches should hold. It should be community-driven and not driven by the health facility. We should have government advocacy and policy engagement. Then technology integration. We should take advantage of technology to be able to map out where we have those zero-dose children. If we map them out adequately, we can plan to reach them where they are and not wait for them to come to us. Then strengthening health system and immunization infrastructure to reach underserved population is also very key. Last but not the least, looking at leveraging community engagement and social mobilization through public-private partnership. We cannot throw away the private organizations. Some of them have relationships with communities. Let's bring them into the immunization space. Let's bring them into the immunization sector and learn. For instance, almost everywhere you go, there's connectivity for phone call. How can we get those telecommunication providers to be advocates for immunization in wherever they have reach within our country, within our region? Next slide. I think the next slide is my last slide. In conclusion, zero-dose reduction is key to achieving global immunization targets. Challenges exist, but the progress is definitely within reach. Strengthening local accountability and governance is very crucial to reducing number of zero-dose. Collaboration with community leaders and other stakeholders, especially the private sector, is very essential. There is need for continuous monitoring and data-driven interventions that will build a stronger health system. And lastly, I'd like to say that let's work together to ensure that no child is left behind. Thank you very much.
Thank you very much for that insightful presentation, Dr. Waziri. As we have heard, achieving our global immunization targets hinges on effectively addressing the challenges ahead. While we face obstacles, we also have tangible opportunities for progress. Thank you, Dr. Waziri. A quick reminder at this point, a pre-webinar questionnaire link has been shared in the chat box. Please take a moment to fill it out if you have not already. Remember, completing both the pre-webinar questionnaire and the post-webinar survey, along with your active participation during the webinar, will qualify you to receive a certificate of participation. So be sure to take advantage of this opportunity. Your certificate will serve as a recognition of your commitment to advancing immunization efforts and contributing to public health. So don't miss out. Now we turn to our second session for the day, where we will learn about the implementation of the Identify, Enumerate, and Vaccinate strategy in Zamfara State, Nigeria. This session will be led by Dr. Belinda Uba. She is an experienced public health professional currently serving as a routine immunization lead for the N-Stop program at AFINET Nigeria. Dr. Belinda leads initiatives focused on routine immunization and has been instrumental in advancing public health efforts in Nigeria, particularly in addressing challenges related to immunization coverage and disease surveillance. Dr. Belinda Uba, the floor is yours.
Thank you very much, Margaret.
Dr. Belinda, we can see your screen.
Okay, thank you very much. I hope you can see my screen now.
Yes, we can.
All right, thanks once again. I'm glad, thanks for the opportunity to make this presentation and share lessons from the Identify, Enumerate, and Vaccinate strategy that AFINET implemented in Zamfara State in northwestern Nigeria. Before I move ahead with my presentation, I just want to recognize that this presentation or this strategy was actually implemented with technical and the financial support from the. I'm going to be taking us through this outline. We're going to look briefly at the background. We'll talk about the IEV process, and then we look at the best practices in the course of implementation, the challenges, and how we're able to mitigate against them. I'm going to discuss some lessons we learned in the course of implementation, and then we end. Let me stop here to say that we are not having to finalize our data analysis and share with the state as well as our funding organization. So we'll be sharing our lessons learned from the implementation. So Nigeria aligns with the Immunization Agenda 2030, as well as the global mandate of leaving no child behind from assessing immunization, as well as other services in the globally. Nigeria, as one of the countries, is accounting for over 2.1 million doses of zero-dose children, and is currently the highest contributor to the number of zero-dose children globally. With the rising cases of vaccine-preventable disease outbreaks that we've been having in the country, is actually a true reflection of the poor routine immunization coverage we have. And like I mentioned earlier on in my introduction, with the financial and technical support from USCDC, AFINET actually implemented the IEV strategy in targeted local government in Zamfara State, which is one of the states in northwestern Nigeria. And we'll be sharing the lessons we learned in the course of the implementation. So the IEV strategy, which is Identify, Enumerate, and Vaccinate strategy, is one of the NPHCDA strategic blueprints as well as priorities for zero-dose reduction. It's actually focused on identifying zero-dose and under-immunized children for targeted micro-planning as well as interventions. It is being implemented as one of the strategies under the Identify and Reach strategy in the IMA framework for zero-dose reduction, which is recognized globally. What is the objectives of the IEV strategy? We actually set out to obtain reliable geocoded data that will help us enhance micro-planning, be able to map out zero-dose and under-immunized children. We also set out to reduce the proportion of zero-dose and under-immunized children in the targeted areas. Equally, to build the community linkage activities to health facilities, as well as foster continuum of care for both immunization as well as PHC services. We equally set out to enhance community surveillance for vaccine-preventable disease. So we didn't just go out to identify, enumerate, and vaccinate, but also to strengthen surveillance for vaccine-preventable diseases. What was the approach we actually deployed in this implementation? Like the name says, identify, enumerate, vaccinate. Initially, we had to identify, and for this, we had to obtain geocoordinates of all structures and households in all the settlements in the targeted local government areas. Equally, we had to identify households that had under 15 children. Under the enumerate, we had to enumerate all the under 15 children and line list under 5 children with all the details of their past vaccination history, either using the child health card or getting history from the caregiver. We had to vaccinate the eligible line listed under 2 children that required routine immunization antigens. I just want to pause here to mention that in the approach that we deployed in Zamfara State, we had to conduct concurrent vaccination with enumeration, meaning that as the enumeration teams were enumerating these children, eligible under 2 children were referred to the vaccination teams for vaccination at the same time. We limited this to under 2 because currently our routine immunization is still covering under 2 children. We have not expanded beyond children less than above 2 years. We equally had to link these children that had been vaccinated to the facilities for follow-up vaccination as well as other PHC services. So what was the process that we actually had to roll out in the course of this implementation? First, there had to be stakeholder engagement. And this engagement cut across the state level, down to the local government level, as well as to the communities. We know that stakeholder engagement is key. This helped us to be able to get their buy-in and also support in the implementation. Next, we had to identify these teams, select them, train them, and then deploy them for both enumeration as well as vaccination. In the course of this identification, we had to develop a standard operating procedure to guide the local government as well as the communities on how to identify appropriate personnel that could be recruited into the activity. We had to then deploy these teams after training to ensure that they map out all the structures across every settlement and wards. In the course of mapping, every household had to be identified, and then household with under 15, under 5, and under 2 children equally had to be identified. We enumerated all under 15 children, and then we had to line list children under 2 years, under 5 years, together with the vaccination status, and then refer those that were eligible for vaccination to the vaccination teams. That is where the children had to be vaccinated, and following vaccination, we had to link them up to the facilities for follow-up vaccination, as well as other PHC services. We equally use this opportunity to update the community registers as well as the registers in the health facilities for follow-up activities. This slide just shows us the different engagements we had to hold with all the various stakeholders from the state level, the leadership of the state, and down to the community level, starting with the traditional institutions and getting down to the community level. Just to mention that Zamfara State is one of the states in northern Nigeria that has a lot of insecurity. So we had to engage community leaders from insecure areas in separate occasions just to ensure that we get their buy-in and plan for the appropriate time to enter those communities. This slide shows the engagement we had at the community level, where we had to pull out all the settlement heads from the different settlements to engage them at the level of the ward. This engagement actually provided an opportunity to sensitize them about immunization and PHC, got their buy-in, and then they equally helped us to generate demand for the activity in their various localities. Following all the engagements, we had to train our teams and deploy them to the field. And the training was conducted in a cascaded approach from the state to the local government and down to the ward levels. The IEV teams were equally trained on the routine immunization schedule, knowing about the key messages to provide during the enumeration, as well as for those that would come into the vaccination post, training them on the vaccine preventable disease case definitions for community, active care search for VPDs, use of tools, as well as vaccine management, adequate documentation, and not forgetting navigation, because it was critical that every household, every structure was actually reached and visited as well as mapped. We utilized the second day of the training for the teams to actually gain some field experience on how to navigate and administer the tool. Following our trainings, we had to go into settlement rationalization. And to mention that for us to be able to cover all the settlements, we had to obtain different available sources of settlement. We utilized data from the master list of settlements. We got validated lists from the state primary healthcare. We also got lists from the local government, as well as catchment area facility list of settlements. We triangulated all those lists of settlements. We're able to map our settlements that were inaccessible, met with the ward teams, and then we're able to sit down and rationalize workload for all the teams. This was utilized, we had to utilize GIS to actually aid us in rationalizing workloads. In some situations, we had to demarcate enumeration areas. In some cases, we had to assign settlement to teams, and this led the teams into developing their daily implementation plans that aligned with the map settlement and assigned areas. Just to mention here that when we talk about the IEV teams compose of an enumeration team as well as a vaccination team. So for this particular purpose, we had to deploy 2 enumeration teams to a vaccination team working in the same settlement, so that the vaccination team was actually mobile, moving from one place to another and vaccinating children as they were pulled out from the various households by the enumeration teams. The enumerators had to make use of coupons to be able to link these children to the vaccination team. These coupons had specific IDs for each child, and that enabled us to track these children and be able to follow them up for subsequent vaccination. Supervision wasn't ignored in the course of this implementation. We had to engage supervisors from the states, the local governments, the ward, as well as partners that support activities in these areas. We equally deployed GIS to monitor the daily coverage of activities by teams, and we had independent monitors. These were ad hoc personnel that we involved, and they had to monitor the activities of both the enumerators as well as the vaccinators on a daily basis and report them back to the local governments. Talking about the monitoring, like I mentioned earlier on, GIS was used to monitor these activities. So on a day-to-day basis, we had to deploy this technology to see areas where teams had covered and areas where teams had not covered. As we could see in the maps above, some of the areas could not be covered, and this is what we had to utilize to follow up with the teams, provide feedback to them, show them the areas that were missed, and then, of course, enable their strategies next day's activity. We equally were having evening review meetings, and the essence of these review meetings was really to get feedback and also address issues that were arising from the field. So we had physical evening review meetings at the local government with all the supervisors as well as the monitors, where the monitors were able to provide this feedback based on their monitoring in the field. And then at the level of the state, we equally had virtual evening review meetings with all the state and local government supervisors. This provided an opportunity for us to review the data and able to follow up with the teams on the next day, depending on the feedback that was available for each team. In order to enhance team performance, we had to continue to provide early morning refresher trainings. This was provided on a day-to-day basis before take-up of teams. In these trainings, we had to look at their previous coverage, identify areas where they needed to focus on, assign new areas because there were settlements that were identified in the course of enumeration that needed to be added to their DIPs. This also provided an opportunity to assign these new settlements to teams and equally follow up on teams that were not performing for them to actually perform optimally in the field. In the course of the activity, we had to follow up on adequate data management. Our data was totally electronic. We utilized ODK to collect data both for the enumeration teams as well as the vaccination teams. And this data was stored on ODK Central. We had to conduct geospatial analysis on a day-to-day basis to track this performance. And the feedback on teams' performance was actually shared with the supervisors for follow-up the next day. Like I mentioned earlier on in my introduction, we are still cleaning this data and analyzing it, so we will not be sharing the results of this activity in this presentation. Like mentioned earlier, Zamfara is really a security compromised area, and we had to come up with a separate plan for reaching some settlements or wards that were totally inaccessible. We could not just deploy a full IEV team to such areas, so we had to conduct separate meetings with community leaders from these areas, had personnel identified who were resident in those inaccessible areas, who could at least conduct enumeration activities. Just to mention here that in some of these settlements in Zamfara State, there are settlements where phones cannot even be used. they are not allowed to move with mobile devices. So we had to deploy paper-based tools for data collection. And these carriers, when the enumerators were able to enumerate, the caregivers had to be mobilized out of those locations to a safe area of their choice for targeted vaccination where it was feasible. At some point, we had to deploy teams at periods where they were not striped, just to ensure that the activity actually happened. Like I mentioned, these are areas where mobile devices cannot really be used, so we had to deploy paper-based. So having gone through this, what are some of the best practices that we identified in the course of this implementation? One key thing we saw in the state is the fact that we had a strong leadership, ownership from the state in the implementation of this activity. It was led and supported fully by the state, and they were able to drive the process through. There was active participation of all stakeholders in the implementation, both the state government, the partners, and the community as well. The use of coupons to have specific child ID helped us to be able to link enumerated children to the vaccination team and know if their status of vaccination was completed or not. Equally, the concurrent vaccination, which we actually implemented as the approach for this IEV, actually helped us to reduce missed opportunities. Because if we had done that afterwards, there was a tendency that we could have enumerated children. And then when we deploy vaccination teams afterwards, they might not be available for vaccination. We equally leverage technology to monitor teams' performance. And this was one best practice because teams now knew that they were tracked, they could see their performance the previous day, and they improved subsequently. The deployment of a responsive approach to reaching inaccessible settlement was one best practice. There are times that we had to be engaging community leaders from those areas at periods that are just safe for them to come out, and times that are safe for us to also pull out the caregivers for vaccination of those children. It wasn't without any challenges. It's in insecure areas. We had banditry, kidnapping, and all sorts of insecurity. We had difficulty in getting capable personnel from these areas that are inaccessible, as well as some interference in the course of team selection. We came up with a couple of mitigation actions, engaging the community leaders from those areas, having a separate plan for inaccessible areas, being able to utilize the gatekeepers of those areas to access those settlements, and then enumerating and pulling people out to a safer location for vaccination. Daily refreshers actually helped in building capacity of this personnel, and then we had to ensure that the tools were simplified. We continued to engage the leadership to ensure that adequate and appropriate personnel were recruited for this activity. What lessons have we learned? In the course of implementation, we learned quite a couple of lessons. However, we are sharing these few. One thing, it was a concurrent activity and we had to be vaccinating. So vaccine management had to be intentional to ensure that we did not have wastage of vaccines because we had to deploy so many vaccination outreach teams at the same time. The concurrent vaccination equally helped us reduce missed opportunities. We integrated these services with other PAC services, and that was able to address some felt needs and generated demand for us. The daily refreshers actually improved team performance. The implementation approach, which was actually concurrent for us, one lesson we've learned is that it is a very capital intensive activity and micro planning has to be meticulous to be able to implement. The ownership from the state for us was something that was a big lesson. The purposeful advocacy that we deployed promoted that ownership. And right now, as I'm presenting to you, the state has requested that we train other local governments where this has not been deployed so that they equally utilize their own resources or source for resources to deploy this strategy. That shows that the state is already owning this and running with it. So to conclude, I just want to mention that IEV is a strategy that is capital intensive. Though being as it is, if well implemented, it's an innovative strategy that can help us reduce the burden of zero-dose children, enhance micro-planning, strengthen community linkage activities, enhance surveillance for VPDs, particularly in these areas that are actually considered as consequential geographies, and overall help us to improve the coverage of routine immunization in our countries. Thank you so much for listening. Thank you, and over from me.
Thank you, Dr. Belinda Uba, for that enlightening presentation on the implementation of the IEV strategy in Zamfara State. It's clear that the IEV represents a significant strategy to reach zero-dose children, while there is a critical need for targeted outreach and tailored strategies to ensure these children receive the vaccinations they need. Thank you very much once again. We now move into the discussion and experience sharing segment of today's webinar. This is an opportunity for all of us to engage with the speakers, ask questions, and share experiences from our own work. Please feel free to raise your hand or type your questions in the Q&A box at the bottom of your screen, and I will call on you to contribute. I see some hands raised here. I'd like to call upon Osman Bello. Osman Bello, we will unmute you and you are free to speak now. Your question or your contribution, please. Osman Bello, can you hear me? Your question, sir? Jamila Buhari, let's move on for want of time. Jamila Buhari, your question or your contribution, please. Can you hear me, Jamila Buhari?
Yes, I can hear you. Am I clear? Can you hear me?
Very loud and clear. Please go ahead.
Okay. Good afternoon, all. The Immunization PhD Advisor, Uganda. I'm very happy to see you once again. The RI Lead, AFNET, Dr. Belinda. It was a wonderful presentation. My name is Jamila Buhari, the NSLO, overseeing Dala and Ngogo LGAs. Ngogo LGA is vast in terms of landmass. It has both urban and rural profile, and is also densely populated, characterized by rapid expansion. As a result, it has new settlements that cannot access immunization services, which led to high number of zero-dose children. What is your advice on how to address these challenges in order to reduce the number of zero-dose children? Thank you. And over.
Dr. Belinda, would you like to answer that question, please?
Okay, thank you so much, Margaret, for the opportunity again. And thanks, Jamila, for that question. I heard you very clearly about Ngogo LGA with a very landmass, a wide landmass, and having settlements that are far apart and difficulty in accessing services. Yes, so how do we get to reach these communities as well as these children who are in these areas? I will start by saying that it is already good that you've already identified the situation of the LGA, that settlements are widely displaced far apart. So the first thing is knowing where these settlements are and being able to map out these settlements. We know that right now for Nigeria, for example, our current real strategy says that children that have communities that are located beyond 5 kilometers should actually be planned for mobile services. And as a result of this, because of the cost involved, a couple of communities are being missed out because the funds are not there to actually provide for mobile services. So it's for us at that local government level to actually have a very holistic micro plan on how to reach out to these settlements. Because once you don't plan to get to this settlement, you definitely will not be able to reach them. So develop a holistic micro plan that can help you reach out to this settlement and then conduct targeted activities in those settlements. I will not say go and implement IEV because it depends on whether you have the resources or not to be able to implement IEV. Like I mentioned, IEV is a very capital intensive activity. If there's a support, that would be very nice. You're able to know how many of these children are there and then plan for targeted activities. What I would say holistically is have adequate micro plans solicit for support from the local government, and then conduct activities in those areas. Not necessarily from the health facilities, because it is already clear that the settlements are far away from these facilities, and outreach from. So it is now the responsibility of the LGA to plan and ensure that services get to those settlements that are actually far away from the facilities, that their routine outreaches cannot be reached. If we have this kind of holistic plan from the local government areas, we can be able to reach those settlements and definitely be able to vaccinate those children who are now being seen as contributing to the burden of zero-dose children in the local government. Thank you.
Thank you for that detailed response, Dr. Belinda Uba. At this point, we'd like to take a set of questions targeted to both presenters so that they can speak to them and address those questions. I'd like to call upon Adaora Odis for your question or contribution, please. Adaora, can you hear me? Please go ahead.
Yes, I can. Thank you very much for this webinar. I'm very, very happy to have learned a lot from our two speakers, Dr. Waziri and Dr. Blender. I'm in Lagos, and most mothers give birth in TBAs. Now, how are we going to identify those children with zero dose and missed opportunity if we don't have any data or whereabouts, their addresses and so on? For me, I think we should kind of collaborate with those traditional birth attendants in Lagos and also engage with schools, because sometimes, like I had this implementation I did 2 years ago and last year, and I found a lot of missed dose and few zero dose in some schools in a local government, Christopher, in Lagos State. We also found them in churches when we went to do sensitization. But my problem is not these wonderful ideas or wonderful implementation ideas we all started or we have all implemented and carried out very well. My problem is after the project ends, because this is capital intensive, and sometimes we don't have funds to continue for about 10 years, 5 years. After the project ends, how do we ensure the continuity of these are wonderful ideas, fantastic work we have done, so that we don't end up going backwards, losing, all the good things that we have started? I think we should collaborate also with the government workers, like the primary health care of the various places we are, like for this project that was implemented in Zamfara. If the project ends, I hope that the government workers in Zamfara will pick up all these ideas, the strategies, and continue from when they stop. Thank you.
Thank you, Madam Adaora. Presenters, please be taking note of your questions, and we move on to Noura Mohammed Goronio for your questions. Please keep them short, very brief questions to the point. Noura, please go ahead. Please keep it very brief. Let's move on to Al Hassan Umar Adamu for your question or contribution, please.
Hello, sir. Hello, ma.
Yes. Yes, is this Noura?
Hello, ma.
Can you hear me? Yes, please go ahead. Your question or contribution.
Yes. Am I audible now?
Yes, you are. Go ahead, please.
All right. So my name is Noura Mohammed Goranyo from Sokoto State in Gada LGA. Gada LGA is part of LGAs that implement this IEB strategy. So the major problem that we're having in Gada is data discrepancies between data clerk and house-to-house teams supervisors. So my question is that how do we mitigate these data discrepancies between these two parties between team supervisors and the data clerk. Thank you very much, and over.
Thank you very much for keeping it brief. We move on to the next person, Lizzie Igbine. Lizzie, your question or contribution, please.
Thank you very much, and good afternoon, everyone. Please, my question and contribution is, what do we do in farming communities where we find out that there are these opportunities? And also, what will be the incentives for us to gather those women to participate in immunization where it is not very close to their locality? It's an issue around our farming communities. I don't know if we can provide any solution to this.
Thank you very much for your question. We move on to Bashar Lawal Bugundu for your question or contribution, please. Bashar Lawal. Mr. Bashar, can you hear me? We move on, please. We move on to Peter Ohonsi Ehizibolo, please, for your question or contribution. Peter?
Hello, good afternoon.
Good afternoon, sir. Please go ahead.
Thank you for the wonderful presentation. My question is just around the security problems we're having in Zamfara.
Yes, please.
So I don't know if there are opportunities and also methods by which we can be able to navigate these challenges so that we can vaccinate zero-dose children within those communities. Thank you. Over.
Thank you, Mr. Peter Ehizibolo. Moving on to Zaliha Saidu for your question or contribution. Zaliha. Zaliha Saidu.
Hello, ma.
Yes, please go ahead.
Hello, ma. Can you hear us?
Loud and clear. Please go ahead.
Oh, yes, ma. I'm Zaliha Saidu from Bokura Local Government of State, CAFS, representing Renewal. The issue from my side is new incentives are giving some of our people money before vaccinating their children. So we have a lot of under-immunized and zero dose. So some of our people are not giving their children because of that money. How are we going to convince the people to accept it? And secondly, we have insecurity issues. So how are we going to track the people from insecure area to vaccinate their children and the under-immunized? Thank you, ma'am.
Thank you very much. And the last question for this segment, Isaac Igbaver, your question, please, contribution. Igbaver Iren.
Hello?
Yes, please. Go ahead with your question.
Oh, thanks. Yeah, great presentations, Dr. Waziri and Dr. Oba. It's good to see the incredible work that is happening to reduce the number of zero-dose and partially immunized children across Nigeria. Mine are just comments. And in Dr. Waziri's presentation, she actually recommended the use of technology, which I feel is very important. And not just using technology, but using it the right way. So I feel like in the way we document immunization in Nigeria, if we need to have an idea of every dose and a child takes. And that's where systems are going, to be able to identify exactly what dose and a child take, unlike just having aggregate number of children, and because sometimes these decisions are driven from bottom down. because when you make them understand that this is where the children are, then it gives better insight into understanding what's happening, and then developing interventions to actually get there. So if we start documenting children properly, like electronically, and anybody from anywhere within the system can see where the children are, then they can actually do interventions that will actually reach those children. That's one. Then talking about workload for healthcare workers, I think I know a lot of work has gone into this, but one other thing we need to be thinking about, particularly when we want to talk about integrating immunization services, routine immunization services with other services, we should be thinking about an implementation research to actually understand how the workload combining immunization and other healthcare service delivery activities in the health facility impact the services of the delivery, service delivery as far as healthcare workers is concerned. Because yeah, it's true that when you overwhelm or you overwork healthcare workers, they may tend to even be aggressive to caregivers and possibly neglect services that they feel are not important. And of course, preventive services seem to be less important when you compare them to acute treatment services or therapeutic services. So these two areas are areas that I think and AFINET can actually, I don't know if that was included in the monitoring and evaluation bit of the zero dose learning project, but it's something that AFINET can collaborate with funding partners to see how they can conduct an implementation research into understanding like number for number and basically putting words together to understand what this is and what this means to healthcare workers, and then developing interventions to address that. Then to Dr. Uba's presentation, great presentation and great work. Great to see that good work is going on. But there's something I call capacity and empowerment. So when you build capacity of traditional, those at the grassroots who should actually be leading immunization or vaccination services across the states and across the country, are there strategies are there ways that you are advocating for them to be empowered? So one of the things I think that can be done is that when you engage governments, particularly at the state, local government, and federal government levels, you should think about how, apart from empowering them, apart from building their capacity and giving them the knowledge and telling them what to do, you give them, you actually tell them, advocate for them to be empowered, either financially or in any way that the government can, and developing step-by-step monitoring and evaluation structure to be able to see that when you empower them, when you give them resources, you also see track to see that the work that you want them to do is actually happening, and the results that you want to see, it's actually working. And if it's not, then you begin to think about what other strategies can you develop to actually address some of the issues that you are noticing despite implementing empowerment and then capacity building. I think these are three comments that I think are very critical in adding to the work that's happening. But great presentations and great work overall. Thanks.
Thank you, Igbaver. Thank you for your contributions. We move on and we first take our first presenter, Dr. Waziri. We'd like you to come up and respond to the questions, the contributions from our participants. Dr. Waziri, please, you have the floor.
Yeah, thank you, Margaret, and thanks to all our participants for very great questions. It shows that people really followed the presentation. I think Dr. Belinda tried to respond to the one of Ungugu. Maybe just to quickly add that, like I said during the presentation, it would be good to develop strategies that involves the community. So it's like Belinda said, any settlement that is within 5 kilometers is supposed to have mobile sessions planned for it. I hope I got that right, Belinda, for the Nigerian strategy. However, funding does not allow that. if funding doesn't allow that, how can we plan with the community to ensure that we fix immunization on days that are convenient for them and also convenient for the healthcare workers? I talked about flexible scheduling. And then it's also very, like Belinda said, it's very good that we know where they are. So the first thing is even identifying where these zero dose or mixed communities are, and then looking at strategies that suit them. There's no strategy, there's no one strategy that fits all. So it's not one cap fits all. We just have to innovatively and working collaboratively with the communities using a human-centered design to come up with strategies that will solve the problem for each community. In terms of, interestingly, to hear that in Lagos State, most women give birth at TBAs or with TBAs is very interesting, because you will expect that a state like Lagos, you will have more health facility delivery. But I think since we already know, it will be good for us to set out intentionally to map where these traditional birth attendants are. Are we going to be able to get people to stop practices that they are used to overnight? No. But if we can have a registry of all these TBAs, link them to health facilities, so that as children are being delivered with those TBAs, they are immediately linked to vaccination, where we're using DPT1 as a measure of zero dose. But I tell you, the bat dose, hepatitis B bat dose vaccination is so key. It's very, very important. So we need to think of how to have linkages with those TBAs to healthcare services, so that they can also refer those caregivers that deliver at their centers. Or even if some TBAs are so large, if some TBA centers are so large, I think we can also work around seeing how we can have vaccination, because most people that go to give birth there means that they've been going through antenatal there. The TBAs have their registers, they know how many women are going to give birth within a particular period of time. So we can also plan vaccination sessions in the TBAs. It's interesting to see that zero dose children in schools are 2, maybe the daycares, but I want to also believe that a parent that can take the child to a daycare, because for Nigeria, routine immunization policy allows vaccination of children under the age of 2. Once they are above 2, the policy doesn't allow administration of routine antigens. So if we have a child that is under 2 that is attending school, it means it's a daycare or nursery, and any parent that can go to nursery, that can take kids to nursery, has some level of education. So it will be good for us to enlighten the parents and sensitize them on the need for their children to be vaccinated. For churches, yes, I expect, because mothers will go with their children to church. So also we can use the church system to sensitize our caregivers about vaccination. In terms of new incentives is actually the money they give to caregivers should reduce our number of zero dose. Because if a mother knows that if she takes her child to the health center and the child gets vaccinated, she's going to get some money, then it should be an incentive or a driver for her to take it. However, we've not seen that increase. So we still need to ask ourselves what is being done or what is not done right. I don't think new incentive is the problem, because based on what new incentive does, we should have an improvement in coverages wherever new incentive is. I think there's still an issue around education, around sensitization, around building trust, and then also access to vaccination. Isaac talked about use of data. Yeah, I agree. We have to use data and use it right. If we can transition from having aggregate data for immunization into having case-based data for immunization, that would be good. So for every child that is being vaccinated, the data is there per child. That would be excellent. And I think that was what the electronic management of immunization data was supposed to do, EMID, because EMID takes case-based data. That was what we used for COVID vaccination back then in Nigeria. If that EMID was supposed to have been transitioned to routine immunization, if that transition happens, I think then we'll be one step into getting case-based data for routine immunization. I think I'm going to stop here and let Dr. Belinda take the remaining questions. Thank you.
Thank you very much, Dr. Waziri, for your responses. I'm really learning a lot from this webinar, and I'm sure you are too. There's so much valuable information being shared, so I encourage everyone to take notes and capture any key takeaways. Dr. Belinda, please take the stage. Before we like to remind our participants, drop your questions in the Q&A box. For want of time, we may not be able to take all questions, so drop your questions in the box. The presenters will answer them live. Belinda, over your responses, please.
Okay. Thank you, Margaret. And thanks for the questions, the comments, the suggestions. It's clear that we really were following the presentations. I will look at the question from Adaura around how do we ensure continuity of this project when it ends and the need for collaboration. I think one thing I mentioned in my lessons learned was the fact that this project was implemented with the state's primary healthcare development agency, with the local government, with community leaders. It was a holistic implementation. All the stakeholders were brought on board in planning and in implementation. That already showed leadership, ownership, and acceptability of the project. Even though, like I mentioned, it is capital intensive, we work with personnel from the state, from the local government, from the facilities. So the people that we trained and deployed were health workers. The vaccinators were the health workers. Some of the enumerators we use are the personnel we've always been using for most of the activities. So we actually build capacity of personnel that are already in the system, and this is an activity that can actually be sustained. And like I mentioned, even though we are limited to certain geographies, there's already that request to build capacity of activities can actually be implemented there. So one key thing is carrying the state along for ownership, building their capacity, which we have done. We've equally generated data. We did IEV, right? We're able to generate data, as I mentioned in one of my objectives, for micro-planning. So we've generated data that is geocoded. This data is supposed to now be used for micro-planning to ensure now that we plan for sessions to reach out to all settlements. In the course of this implementation, we picked settlements that were not even in any of the list of settlements that was handed over to us. We had more than 5 sources of settlement lists that we're triangulating, but we still identify settlements that were nowhere. So we've generated data that is geocoded, that is going to be used for micro-planning, not just for routine immunization, for polio and non-polio ASIS, as well as for surveillance. That's already for the system, so that even after we stop, all we wanted was to generate data. Now the data has been generated. How do we support the state to plan? And then when they plan, it is the routine resources that they should now utilize to actually ensure that routine activities are actually ongoing. Secondly, we're able to link communities with some of these health facilities. And I just want to mention here that there are communities we went where for the last 3, 4 months, 6 months, they have not had any health service. And they were like, we have not seen health for time. What has happened? So that excitement, we were able to link them up. And linking them up to the facilities means that now they have access, the facilities now have to plan and be able to reach out to them. And engaging the communities also had to do with them owning this program so that they understood the value, they accepted it, and they now know that on their own, they can actually call out for health workers to actually come when they are not seeing them actually coming around to actually provide the services. So there are a lot of opportunities around sustainability for this activity, even though it might not necessarily be rolling out an IAV, but ensuring that immunization and PHC activities are actually reaching out to all these settlements that will actually help them map out. These children have already been geocoded. They know where they are. So it now provides an opportunity for defaulter tracking. The data is there. We have updated the health facility registers. They can now be able to pick up and be able to locate the child to the household where they are and follow them up for subsequent vaccination. There was also something around, I think Dr. India has talked about the women and their involvement. The security in Zamfara, yes, this was implemented in Zamfara State. I think it was Peter. How do we navigate the situation? Like I shared the lessons during our implementation, we worked in very security compromised local government. Today, a settlement is security compromised, is totally inaccessible. The next 1 week, you can go there. So the first thing we had to do is ensure that there is targeted engagement. And like I mentioned, even though we had to engage the traditional institutions, we had a targeted engagement of community leaders from inaccessible areas and equally engaging the gatekeepers, in quotes. If I mention gatekeepers, I'm sure we understand. There are situations where the gatekeepers of those inaccessible areas had to be engaged because they equally understand the importance of health services. And they were able to say, okay, we are going to open up, but you know what? It must be people who are in this community that can provide those services. We are doing enumeration and vaccination. It might be easy to enumerate, but for vaccination, you need qualified healthcare workers that can do that. Such was challenging. So in such situations, yes, let us enumerate and know the numbers. But then how can we plan during a safe period? These women can be able to come out and get them vaccinated. So I think it's about engaging these communities, following up with the trend of the security situation, knowing when there's a safe period and knowing how to get in. And of course, you're not just getting in yourself. You're not the one that is going there because they don't allow strangers. You have to get people from those communities to be able to go there and vaccinate. And in some situations, they decide on where the caregivers have to come out and settle for vaccination because they also do not go to facilities for issues also known in those areas. So it has to be a kind of community-driven intervention, interaction, and then making the decision on how those places can actually be assessed and navigated. I think the other things were comments. We heard from Isaac very well. Thank you so much. One thing we have tried to do is empower these communities. And one thing we believe is that once the community is empowered, even if the funding are not there, the community always have a way of using all the structures available, the WDCs, the VDCs, they always have a way of supporting health workers to actually provide services in their communities. When they are empowered, they know the importance of these services, they can actually support and ensure that services actually get to them. So thank you so much. There was a question from Nora, but Nora, I don't know whether it's really aligning to what we presented today. You are talking about discrepancies between data of different, the house-to-house team and the others. I think, I don't know if it was for our presentation, but issues around data discrepancy, I think we might want to chat with you afterwards and address that. Thank you.
Thank you very much, Dr. Uba, for those responses. We are now moving into the second segment of our questions. I'd like to call upon Al-Hassan Umar Adamu for your question or contribution, please. Mr. Al-Hassan Umar, you hear me?
Yes.
Please go ahead.
Can you hear now? Oh, fantastic.
Loud and clear.
Thank you very much. Thank you very much. Fantastic delivery by the two presenters. And I say kudos to the consortium, the implementing partners for doing a very good job across the country. My name is Dr. Adamu Al-Hassan Umar, and I work in Borno State. And of course, having monitored the various advocacy engagements and of course the direct immunization monitoring survey that was conducted in Borno State, and of course as a health worker myself, who is very much aware of the myriad of challenges encountered by caregivers in assessing healthcare due to obvious reasons that of course have been highlighted as part of the presentations, particularly out-of-pocket expenditure, and of course with the many of our children malnourished, and of course living in a crowded environment with the antecedents, conflicts that exist in this part of Nigeria. There is actually a need for a holistic approach to tackle zero dose by all partners and government towards, of course, creating a central platform to address the challenges of access to healthcare services. nutritional support for children, educational needs for children, and of course their caregivers, among others. Now, there are some of these challenges, plus of course the insecurity that has been highlighted already that act as compounding agents, towards hindering access to routine immunization in the affected communities. Now, my question to the consortium is this: what efforts are being put in place to escalate the lessons learned from the implementation of the zero-dose learning hub in the states of Kano, Sokoto, Bauchi, and Borno, and of course the identify, enumerate, and vaccinate module that is currently working in Zamfara State to other zero-dose states across the country? And of course, are there efforts to holistically address the issue of routine immunization, not only immunization alone? For example, the IEV model that is working in Zamfara State. Are there efforts to align with other partners that are rendering nutritional support, educational support, and what have you, so that there will be a holistic approach at ensuring that no child is left behind? Thank you very much, and congratulations once again.
Thank you very much, Mr. Al-Hassan. Next, I'd like to call upon Hadiza Jibril Ahmed for your question or contribution. Please, I'd like to implore you keep it brief as possible. Hadiza? I think she dropped off. Murtala Sani, please. Murtala Sani, your question or contribution. Murtala Sani.
Okay, can you hear me, ma?
Yes, please.
Okay, thank you very much. Thank you very much for your wonderful presentation. I have a contribution to give here as an advice, ma. During IEV implementation, we have experienced a lot of problem pertaining enumeration teams in Zamfara State. That is why I think it is so vital to give my advice to the ICT, if it is possible. Please, the ICT should reduce the length of that enumeration checklist next time, because the structures that our teams captured in a single checklist, it has become very confused one. That is why you can see our daily day-to-day data. Some of our teams didn't attend the daily target because of that confusion in that checklist. Due to that, please, you can call for that ICT to please minimize the checklist for easy manipulation. Thank you, and over.
Thank you very much, Murtala. That has been noted. We move on to Ifeanyi. Ifeanyi, your question, please. Kindly be brief. Ifeanyi, go ahead.
Okay, good afternoon, and well done. Thank you for the presentation. Please confirm if you can hear me.
Yes, we can. Please go ahead.
Okay, so my question is in regards to data, because the earlier presentation, we are actually focusing on the fact that we have some security compromised areas that don't allow phone or digital devices for them to access and get data. And we all know that data is actually one of the driving factors of this activity. So my question is there any other alternative that we can use to validate the authenticity of the data that's being generated based on paper base? Because we are being careful to ensure that every data that is being generated is real-time data, and we know what is actually happening, especially areas where you don't really have eyes to supervise or know what is actually happening at the ward level or settlement level at the security compromised areas, because we know the peculiarities of these occurrences in this area. So these are just my question, and thank you, and over.
Thank you, Mr. Ifeanyi. Thank you for your question. We move on to Kabiru Bandado Ibrahim. Before Kabiru, I'd like to just remind you all, feel free to drop your questions in the Q&A box. The presenters are answering those live right now. We would also share all the questions and responses from the presenters after the webinar in the webinar resources we'll be sharing with you. Right now in the chat box, you would see links to all the webinar resources, the past 3 webinars. So feel free to download these resources before the end of this webinar. Kabiru, your question or your contribution, please.
MashaAllah. Thank you very much, Ma, the moderator. I hope I'm audible, Ma.
Yes, you are, sir. Please go ahead.
Okay. Thank you very much, the moderator, and thank you very much, the ARPANET Immunization and PSC Advisor and RI Team Lead for the very good presentation. The presentation is actually in line with the current operational realities in our various LGS. I am Kabiru Bandadu Ibrahim, NSLO from Goranyo LGA in Sokoto State. My LGA is one of the 13 zero-dose LGS in the state. Initially, I wanted to ask on some of the best practices applied in Zamfara experience, being that my LGA shares some profiles based on insecurity and some bad terrains and riverine areas like in some part of Zamfara. But my first question was addressed by the second presenter. She has done justice to the question, especially what stood out on the issue of concurrent vaccination. It is actually applicable in most places. Thank you very much for that. That part of the question was addressed in the course of the presentations. And the second part of the question is that being in the zero-dose LGA, we have employed an unconventional strategy whereby based on the IEB experiences, we went on in some settlements. We have conducted SIB and enumerate the zero-dose and unimmunized children. After that, we sent some vaccination teams in those areas, but unfortunately, there is vaccine on hesitancy. After so much advocacy and effort, still the vaccination teams could not, and the caregivers could not cooperate with the activities. What we did next is that we use an unconventional house-to-house approach, house-to-house vaccination. We send the vaccinator going house to house with the list of the enumerated children, and we use some detergent as an incentives, and we have done that successfully, and it works. So my question is that what is the position of the consortium or of the program on this our strategy? I mean, house-to-house strategy and the use of detergent as incentives. By doing that, we have vaccinated many of children that we enumerate as zero-dose and unimmunized children, and it works for us. What is the position of the program and the consortium? Can we continue with that way, or what is the advice? Thank you very much. I hope I'm audible enough and my question is understood. Thank you very much, and over.
Thank you very much. Thank you very much, Mr. Kabiru. That was well noted. We now move on to our presenters, Dr. Waziri and Dr. Uba. We'd like you to make your responses as brief as possible. Dr. Waziri, the floor is yours, please.
Thanks, Margaret, and thanks to all the attendees participants for the question. I think there was one question that I missed out, and it was typed in the Q&A box, and I wanted to take it. There was a question around the states with the highest number of zero-dose children. So just to mention that, interestingly, most of the zero-dose children in Nigeria are located in the northwest part of the country. So amongst the first 10 zero-dose states, we have Kano, Sokoto, Bauchi, Borno are the only northeastern states included there. Then we have Katsina, Kaduna, Jigawa, Zamfara. And in somewhere in the middle, we have the north central states, we have the southeastern states. But also, interestingly, the states with the lowest number of zero-dose children are the southeastern states. So we have Enugu, Ebonyi, Edo, Ekiti, Anambra, Imo. Those are the states with the least number of zero-dose children. So I felt I should just mention that. For the questions that were asked now, so when we talk about workload for healthcare worker, thanks, Isaac, for that comment. I think, yes, we haven't looked at the workload because we always talk about integration. And why we talk about integration is if you go to the facility, it's the same healthcare worker that provides all the services. And then it's the same caregiver that is also bringing the child to the facility. So can we integrate? But I think we need to look at how that workload is, the healthcare worker, recognizing that we have a huge gap in health workforce. How can we deal with that first? And then in terms of infrastructure, there's a question around infrastructure. Really, there's nothing we can do. Me and you can't work on infrastructure, but we can be advocates to the government, to our political leaders, to our philanthropies. We can be advocates for public-private partnership for health facilities, or to either be erected or to be renovated, for cold chain equipment and other equipment required in the facility to be provided. It doesn't always have to be government. We can advocate for public-private partnership as well. So myself and you, we can be advocates for that. However, it doesn't totally rest within our power to improve infrastructure. In terms of, there was a question around TBAs and about 7 out of 10 deliveries. So I'm answering some questions from the chat box as well. 7 out of 10 deliveries in the health, 7 out of 10 deliveries in Bielsa are happening at traditional birth attendance centers. Like I said, it would be good for us to have a registry. Let's map out those TBAs. Let's build their capacity, since people have trust in them more than the health facility. So let's build their capacity. I know there was a time that even on the HIV program was looking for TBAs and building their capacity on safe deliveries and all that. So let's build their capacity on routine immunization. On immunization, the importance, if a woman gives birth at a TBA center, that child should not miss out on vaccination because of where the child was delivered. That shouldn't be a problem. And then no barrier is, there's no way we can say that if we address the infrastructure or the social barriers that will it will solve the issue, because social barriers does not directly, or health facility related barriers do not directly translate to caregivers coming to the facility for vaccination. So all those barriers are cross-cutting. We have to address all for us to be able to adequately improve uptake of routine immunization. Let me let Belinda take the other questions, except if there's another one that was directed directly at me. But the questions are cross-cutting, so Belinda, please take.
Okay, thank you so much, Dr. Andy, and thanks everyone for the questions. Yeah, there was a yes. So there was a question around how we have escalated the lessons learned to ensure that other local governments and other regions are actually keen and aligning to this. So this is part of what we are doing. And also to mention that even before we deployed this strategy, we had shared it with the National Primary Healthcare Development Agency. We equally have shared with the state and also shared in different fora as available, just to ensure that people are keying into it and they align and equally implement across their various localities. Yes, we had planned to integrate with a lot of other health services and commodities. And like I mentioned, it was an integrated approach, right? Yes, so there was that integration in the course of implementation. Talking about the issue with data in insecure areas and how we're able to validate this data. Like I mentioned, insecure areas is a challenge. Supervision is a challenge in those areas. People that are not known cannot just walk into those areas. So all we are relying on is the data that is going to be generated by teams working there. And since nobody is supervising, we cannot be able to say this data is good or bad. But then validation, like we all know, is key. All we tried to do was build capacity of personnel just to be sure that they are actually generating data that is useful, and leveraging with the community leaders to also work with them and actually monitor the implementation of the activities, since we cannot just deploy personnel. But where we had personnel, either from the ward or from the local government who could access those areas, we equally deploy them to actually monitor. These are areas where electronic device could not be acceptable. They are not acceptable. A team cannot move around with an electronic device. If you are met on the road, they search you, they ensure there's nothing. We even wanted to work together with eHealth and other partners in the state to use some tracking devices, but it was not just possible because they did not allow them to come in with anything electronic, even if it is just a Bluetooth device. They cannot carry as simple as you know, anything that is electronic. So it became very challenging. But definitely there are other ways, right? Beyond the data generated, it can always be triangulated with data that is already available, either we have from degree 3. I know that the CDT also works with the GRAPS team that can be able to use satellite imagery and be able to estimate the population of certain localities. That can help us in triangulating data that is being generated from those areas. The last speaker talked about zero-dose LGAs in other places and how, okay, in Sokoto and how this is being deployed. Yes, we had shared the strategy, we had shared the process, including to the zero-dose LGS that had been prioritized for Gavi-supported interventions, and the expectation is that we should implement the strategy. But Sokoto being as it is, there are areas where the caregivers did not accept. I'm not surprised. The question is, I wanted to just find out, did we even engage them to know why they were not accepting? Hearing that you were able to carry some commodities and they accepted means there's a problem. There's something there. There's an economic hardship that is affecting these communities. Did we try to sit with them to address it before even taking resources to them? Because in Sokoto, if you take vaccine to the household and you have not addressed their felt needs, they definitely will not take the vaccine. And here is a strategy. You had to address a felt need as ordinary as soap, and they were able to address felt needs. So what I would just say is that in a state like Sokoto, where you already have like the new incentives, bringing monetary incentives, and caregivers are still not coming out, but waiting for something as simple as OMO that is even cheaper than the monetary incentives. Can the state sit together with these partners and say, how can you support us better? If the monetary incentive is not helping us, is there a way we can look at other non-monetary health commodities that these caregivers are seeing as a felt need? That could be a way out to be able to address this felt need. But it's very clear that the issue here was a felt need that needed to be addressed. So please, I would advise to work with the partners in the state and see how to better plan and position those support that are coming from new incentives to ensure that there's uptake in the state. I think that is it. Thank you.
Thank you very much to our presenters, Dr. Waziri and Dr. Uba, for your enlightening responses. I'm sure all attendees would have enjoyed the interactions they had with you and gleaned from your wealth of knowledge. Thank you very much once again. I'd like to take a moment to recognize Erin Brockheisen, who is joining us today. Erin is the director for JSI John Snow Inc., our global learning partner, and we are truly honored to have her here with us. Her work and leadership in global health have been instrumental in learning and capacity building efforts worldwide. You're welcome, Erin. With that, I'd like to give a quick housekeeping announcements here about how we move forward from here. I'd like to emphasize the importance of being an active and effective participant in our webinars. Please ensure that you register and confirm your email addresses before submitting your registrations. This step is crucial as it allows Zoom to send you a personalized webinar link, ensuring you won't be stranded when the webinar begins. As we approach the end of our session, I would like to invite Professor Yahya Mohammed, the project coordinator at APNET for Zero Dose Learning Hub Nigeria, to deliver the closing remarks and the vote of thanks. Professor Yahya, your closing remarks, please.
Thank you, Margaret. Thank you, our participants. At this note, I want to appreciate our presenters, Dr. Dadin Nasir Endi Waziri, Immunization Advisor, AFINET, and Dr. Belinda Oba, Senior Field Coordinator, NSTOP, AFINET, Nigeria. I want to extend our appreciation for the technical and financial support we received from Gavi, and also the presence of the Senior Monitoring and Evaluation AD, and to our global learning partners, the JSI. With Erin being in attendance throughout the webinar, it really gladdens our hearts. And to our co-implementer, AHBN, to the government partners that attended, specifically colleagues from the National Primary Health Care Development Agency, and also from the 4 implementing states that are here with us, members from academia. I'm happy to see my immediate past provost, Professor Bello Obichari, has been with us throughout, and to all of you that have joined. Thank you, and please answer the post-webinar question. We are going to send a recording of the webinar, the PowerPoints to you, from the first to the present one, and the certificate will be issued for this webinar series. It's a learning opportunity for us, and we are going to continue with this series. Next one will be in November. Watch out for an announcement soon. Thank you.
Thank you very much, Professor Mohammed, for your closing remarks. And with that, we have come to the end of today's webinar. I want to extend a big thank you to our distinguished speakers, Dr. Waziri and Dr. Uba, for their valuable insights, and to all of you for your active participation. Let's continue to work together in reducing zero-dose children and improving immunization coverage across the region. Please mark your calendars. The last and 5th edition of the Zero Dose Learning Hub Nigeria webinar series is scheduled for November 2024. We will share the details shortly via email and on our social media handles. Thank you once again. We look forward to interacting with you in our upcoming sessions. Have a great day, everyone. Bye.